and 2 people have run it 3 times. I can't believe it. The amazing Robin Page and our Dr. Tim Harrison. So we've had 86 runners, and they've run 2,236 miles for us. So I think that's fairly impressive. And we have raised £135,000 via it. So it is a really big money earner for us. So if any of you know any marathon runners, because we do struggle a bit to get runners each year. And it is really lovely if they are associated with the LAM patient, because it gives them lots of incentive to... I see someone nudging someone there. To raise funds, so it's a good one. So these are just thank our top marathon fundraisers. Robin, as I say, has done it 3 times and raised nearly £13,000 for us. Jim Hemmington, unfortunately Claire can't be here today, but he's done it twice. Claire Spencer had to walk it this time. She was in so much pain, but she finished it and she's raised £10,000. And John's friend Darren Whitney, he's done it twice too. So there they all are. I think Robin's the one in the sunglasses in this picture here. So this year we only had 4 runners, so the funds were down a bit, but they're still managing to probably bring in around £10,000, which is fantastic. Yeah, Alex is here, I think. Yes, over there with Lucas. So the money's still coming in. And I want to thank Julie and David very much for being there on the day, but also being there beforehand and doing all the organisation. It is very stressful, isn't it? Oh, and Libby too. Oh, thank you, Libby. Oh, she bakes cakes, great. And John Wood was there supporting, and in fact, we even had somebody interviewed this year on the BBC. So LAM was mentioned on the BBC too, so that was fantastic. And Tom Goodliff for doing the running vests. Thank you all. So we've had other mad sporting fundraisers who also have raised massive amounts of money. And I think a huge thank you needs to go to Rufus, because he just every year keeps bringing in masses of money. And I don't know, he must just have the fittest body, because he just seems to be able to do everything. And Mum Sandra is here, so please pass on our acknowledgements. We really are very, very grateful. Daniel Waitley, I don't know Daniel, but he's raised 3,260. Jenny Young did the Great North Run. The Clitheroe lads, unfortunately, I've forgotten her name, Sarah Sharples, she's a LAM patient, and her brothers, Matt and Richard, and their friend John ran it, but she couldn't be here today because they just adopted a baby, so they're a bit busy, but yeah. So, and Amanda Simpson, who's normally here, I don't know if many of you remember, she lives on the Isle of Wight, and she seems to have some incredibly, shall I say, wealthy and influential friends. So when checks come in, and they have names on them that I recognise, so... and they're from posh banks in the city. And she's raised 5.5, well, I think it's nearly 5.5 now, on her Just Giving page, just by encouraging people to do things for her. So that's fabulous. So other fundraising and donations this year, Shabnam Akhtar, she normally comes as well, she got a group of Year 5 pupils to I can't remember what it was. It wasn't anything very great, but they must have been pretty fantastic at it, because they raised £1,165. So the Freemasons Grand Charity, which we were actually talking about yesterday at our meeting, Freemasons are really good people. If you know any Freemasons, they're always looking for people to give money to. So do please put our name forward. The Grangerist Methodist Church in Woollerton here in Nottingham, every year they send us at least £1,000. So I want to say thank you to them. Many of you may remember Jane Ward, she just doesn't come to meetings anymore, but maybe she's just not a meeting person, I don't know. And she actually works for Lloyds Bank. And as you will see later, we really would like to encourage people to approach their employers if they do matched giving, because extra £500, and all she had to do was ask the employers to match her fundraising. So really good one. The Rose family, unfortunately Carol couldn't come today either, but they are every year they just do car boot sales and all sorts of things for us, and send in a good donation. Paul Arnold, who every year again he's doing something for us. The Hemmington family, again, this is Jim again, but his wife Claire. They've got some lovely family in America who donate money to us, and unfortunately her aunt, who's Delphine, died this year, so the proceeds from the funeral came to us. And the Exeter University Students' Union, this came about as Julie Delancey, who many of you will remember, put us forward as a charity of the year. And it was incredible, really, because they sent this photograph in, and I looked at it and I thought, I'm sure I know that girl. And one of the girls in the photograph lives round the corner from our house, but she was at Exeter raising funding for LAM, and she knew nothing about me working for LAM at all. It was just a total coincidence. So very nice. So, and I want to thank these people because, as you can see, over the years, they have raised a phenomenal amount of money, particularly the Fergusons and Alison Leslie. But everyone I would like to thank. Ken and Jean have already sent in a donation. They say hello to everyone, but they couldn't come today. But another big donation came in today from them. Heather Taylor, she set up the first standing order donation, which is another way you can give to us, and I'm not going to go on about it. But, and there's lots of people that donate but prefer to be anonymous with it. And that's not for tax purposes, it's just because they don't like going on about it. So thank you to everyone. And also to these people. Linda, who had a fantastic web page and raised so much money. The Hutchinsons, who have a couple of these in their locality. So if any of you feel you could take one of these and put it somewhere, it brings in a decent amount of money. So just shops, garden centres. There's a chip shop, I think. So people just put their change in them and it mounts up. The Mullins family, who are tireless with their table sales and garden parties, absolutely fantastic. Rufus again, who I've already mentioned. Helen and Charlie, who are particularly brilliant. And Sarah and John over there, particularly with their Watford Football Associations. And we had a fabulous surprise last week. This courtesy of John Wood. I came in and it was a scrappy little envelope on my desk with an American stamp on, and inside was a cheque for $16,000. So I was delighted, made my day anyway. So this is what's happened over the last 10 years. The blue columns are each year, and that big one in 2007-8 was the doxycycline year. And the red one is the cumulative. So as you can see, it's quite a lot of money. So this year, we think we're probably around the 86,000 mark, which is way back up. Again, probably thanks to that $16,000 donation. But we're blaming it on the recession the past couple of years, but it's going back up again this year, so we're pleased. And since 2003, you lot have raised £700,000, which is phenomenal for so few people. So you should congratulate yourself. What's on today? Well, hopefully you've all got programmes, but if you haven't, let me know and I'll go and get some more done. Mr. Rupesh Bhatt is coming over from Birmingham to talk to us about angiomyolipomas. Simon's going to reveal all about the doxycycline trial. Debbie's here, and Debbie's a fantastic speaker. Not that I want to set her up for a good talk, but she is a good speaker, and hopefully she's going to excite you all with what she's getting up to in the lab. And then we're going to sing happy birthday after lunch. And Dr. Neil Holden is coming after lunch to, we're going to have an interactive session on panic attacks. And then there'll be a question and answer forum at the end of the day with Simon and Anne. There'll be a box in the foyer at lunchtime. I think it's on the little coffee table that's out there. If you just write any questions that you want aired, at the question and answer session on the pieces of paper that are on the tables, and then pop them in the box. Then we can sift through them, and so we don't repeat the same questions over again. So what's out there? There's some very nice research posters, and two of Simon's researchers are coming along. Well, Debbie's here, and Jenny Kane, who's a PhD student, is responsible for one of them, and Zhao Yo, she's a medical student. They're both interested in LAM, and they've both given up some of their Saturday just to come along and meet you. So do ask them questions about their research. They're lovely girls. We have a representative from Air Liquide, Helen Wilkins, who's at the back. Karen, Wilkins, who's at the back. Apologies. And if you have any questions about your home oxygen, she's the person to speak to, and I think she's got some stuff to demonstrate out there as well. Then Jane has potted loads of her plants on from the garden, and so they're out there. Please buy them. She's worked hard. Of course, we've got Christmas cards. We're having a raffle that Irene and John are responsible largely for, but thank you to everyone that has bought raffle gifts. We've been overwhelmed, actually. So despite me thinking nobody had responded to my email, you obviously did listen, so thank you. There's some books down there and a DVD. We've got some T-shirts that were printed up last year, but you can also buy, there are different designs that you can get on the web. I've got some trolley tokens and wristbands that are quite useful. And I want to thank my helpers that have come along. My daughter Sophie's come up from Bristol, and one of my oldest friends, Maggie, who's up the back there, has come from Northampton to help us out today. So I want to thank them as well. And there was someone else I wanted to thank, and I can't remember who it is. I'll do it after lunch when he comes back to me. And I'm not going to apologise for ending on a poignant note, but I cannot possibly end without acknowledging that we lost Alison Leslie this year, and she was an amazing person. She didn't really come to many meetings. She wasn't really a committee person, but she raised thousands of pounds for us, and she really supported the transplant patients up at Newcastle. So that's how I'm going to end. She, was a very special person, and we will really miss her. So thank you very much, and I hope you enjoy the day. We've got some bags. Sorry, a lady embroidered these bags for us, and we're selling them. I've only got 4, but they're £5 each. So please, yes.
Okay, so we're going to sort of change focus now. So we're going to start off the medical and scientific bit of the meeting. And every year we have an external speaker with expertise in LAM, and I think this is the first surgeon that we've had, actually, but don't hold that against him. And I'm very pleased that Rupesh Bhatt's come. Rupesh is a consultant urologist at University Hospital Birmingham, and he's the surgical renal link to the LAM Centre. And when we set the LAM Centre up a couple of years ago, I thought we really need a urologist. So I approached the person who seemed to have the best knowledge of angiomyolipoma surgery that we could find, and somebody that had been very helpful to us when we'd referred him patients in the past. And he straight away said yes, that he'd like to be part of the service, and we've been working together to look after patients with LAM for the last couple of years. And so I'm very pleased that Rupesh could give up his Saturday to talk to us about what he does in Birmingham for patients with angiomyolipoma. So Rupesh, if I can hand over to you.
Do I need to use the microphone? Yes, okay. Okay, thank you very much, Simon. Thank you very much for inviting me to come to speak to you. That's very dark indeed. Can't see the keyboard now. There we go, yes. Very well. Not that ugly. Okay, well, I'll start. The first thing to say, really, is that I'll be talking about angiomyolipomas, or AMLs, is how I'm going to say them, along with LAM. And the talk's one that is I give with Ian McCafferty, who's the interventional radiologist who I work with very closely. So it's certainly a joint talk. And I have to thank him for a lot of the slides he's given me, especially on the radiological aspects. So what I'm going to go through, well, what is an AML? How common is it? What causes it? What's the natural history? How often does it grow? How often does it cause problems? And when it does cause problems, well, what are the signs and symptoms? And how often and how does it tend to present? I'll also be talking about, well, what interventions are available, and should we be intervening? And if we do, when should we be intervening? We've devised a protocol as a rough guide to how to manage these AMLs, and in particular the follow-ups. But this is not cast in stone by any means. And a little touch on some of the future aspects and opportunities. So what is an AML? Well, if you look, let's have a look. Can you see the pointer? Yeah. So this is essentially a benign tumour within the kidney composed of three elements. Angio, i.e. blood vessels, and you can see the nice blood vessels forming there and there. Myo, which is smooth muscle, so not skeletal muscle, but smooth muscle. And fat, shows up beautifully. And what does it look like on scans? Well, let's take this one. So you've got an AML there, and it's glowing, mainly because it's an angio-rich one. So that's a small one. But then you've got this other extreme here. So this is the kidney. This is a CT scan. That's a little liver edge. And you can see this huge AML. And this is what they tend to look like. So this is the kidney from a specimen that's come out. And this is the AML. So they can be quite dramatic indeed. How common are they? Well, you've got some really old series here. So you've got 1969. This is an autopsy series which calculated in men accounting for about 0.02%, and in women almost 10 times higher at 0.29%. Another way to look at it is to do a population-based study, and this is one from Japan that I've put up here from 1995, and they based it, men, the AML rates to be 0.1%, and in women 0.2%. So low figures, and if you look at the world, so if we say the world population is 6 billion, what you'd work out to really is that there are probably about 10 million people out there with AMLs, and 1 million people with tuberous sclerosis complex, and we've got a couple of slides on that later on, associated AMLs. So not massive numbers, but not an insignificant population. What causes it? We don't know what causes it, but we do know there are some risk factors or associations. And these are the first two ones affecting other organ systems. So you have tuberous sclerosis complex and LAM. The third risk factor is being a woman. So what you've got here is that about 86% of women, so if you look at all the studies, and you look at them really. So in overall, 86% of women, it presents 80% of women. As far as LAM is concerned, what do we know about AMLs in LAM? Well, in sporadic LAM, you've got about a 50% chance of having an angiomyolipoma. In sporadic LAM, if there is an AML, it's usually single. It's usually on one side, i.e. affecting one kidney. It's often small, and it's often restricted to the kidney. So the bottom left picture, as opposed to the top right picture, which was really prodding out. Whereas things are different in TSC LAM. These ladies tend to have AMLs which they're much more common, so almost 80% of ladies with this will have an AML of some description. They're often bilateral, they're much larger, and they tend to bulge out of the kidney more often. And they also have a higher chance of causing trouble, so i.e. bleeding, hemorrhage. How do they present? AMLs, by their very nature, are often silent. And so it could be an incidental finding on routine scanning for, say, the lungs or something else, especially the smaller ones. There is supposed to be a classic triad, and my next slide has got it, of flank pain, a tender palpable mass, and blood in the urine. That's hematuria, blood in the urine. And that's not uncommon. Almost 60% present with this, but that's usually a very big AML. It has to be quite big before you can start feeling it. Could also present just on routine testing. So non-visible hematuria, i.e. when your GP or you go to the hospital and you've had your blood checked, you had your urine checked with a dipstick. And then there are some uncommon ones which are essentially a sign that it's really big. So if it's really big and it's starting to press on some certain aspects around the body, then it can have mass effect. So the renal insufficiency, i.e. the kidney's not working that well, could be because it's got so big that it's pressing on normal kidney tissue and stopping it from working, i.e. a late sign. And same again for UTI, urinary tract infections, or anemia, because it's got so big that you might be losing blood into it. Or the UTIs, it's causing a blockage to the drainage of the kidney, and so just like a static pool pond in your garden, you get bugs growing in it, and that's what the cause of a UTI is in this group. So how does it present? Well, what you've got here is, this is the Lex triad. This is the pain, the mass that you feel, and the blood in the urine. And it occurs in about 60% of patients presenting. What do we know about what's going to happen? So if there's an AML, well, what's going to happen to it? The problem is lots of the data is quite old, and it's also on not enormous numbers of patients or people. So it can all be criticised. But having said that, this is the best of what we've got, and we've got to make the most of it. So the first thing to say is that compared to sporadic AMLs, tuberous sclerosis-related AMLs present in a younger age group, are larger, are often multiple, and more commonly present with bleeding. So here's symptomatic acute hemorrhage at 44%. Tumour on average at 9 centimetres almost compared to 5, so almost double. And you've got the age range difference as well. Can we get a handle on the growth characteristics? Well, first off, only 35 patients. Okay, but a 4-year follow-up. And what we've got here is, let's look at this graph first. So this is the number of tumours that grow. And in the light blue, is the patients with tuberous sclerosis, and in the dark blue are sporadic AMLs. And what we can tell right from this graph is that if you've got a TSC AML, it's much more likely to grow. And not only is it much more likely to grow, it's also much more likely to require some kind of intervention. And we'll talk about the intervention in a few slides from now. But in only 4 years, half of these patients with TSC AMLs required some, or had rather, let me put it that way, had some form of surgical intervention. And you're starting to get, I've got some slides on this later on, but you're starting to get a little bit of risk stratification here. So if this is split up between, now this, the light blue is not TSC and the dark blue sporadic. Now we're talking about size. So if we look at the light blue here is less than 4 centimeters, so i.e. the AML being less than 4 centimeters on CT definition, or being more than 4 centimeters, you can see that if they're already big, they're more likely to grow. And if they're small, they're less likely to grow. It's a bit like the prostate, that, actually. Okay. Now, this is, for us, one of the landmark papers. 253 patients. 20% of these patients had TSC AML. And they were re-stratified into those tumours that are less than 4 centimetres and those that are more than 4 centimetres. Now you can see in the percentages I've put that represented less than 4 centimetres, a third of patients, and the majority were more than 4 centimetres. So there's already a bias there that in this group of patients they already had much larger AMLs. But essentially, let's look at this line. So we've got in the smaller tumour size, the percentage that was symptomatic were 23%. Whereas once you've gone over 4 centimetres, then 82% were symptomatic. So you're starting to get a handle on what causes, when do they cause problems, i.e. 4 centimetres, according to this study. And this is borne out by quite a lot of others as well. So that's the one we've had a look at. But essentially, less than 4 centimetres, this is symptomatic at presentation, and you can see, generally speaking, low figures, but much higher when the AML is bigger. So the bigger it is, the more likely it's to be symptomatic. This is looking at what intervention they required and splitting it up. What you can see here is less than 4 centimetres and more than 4 centimetres. And you've got 43% of patients in this study required some form of intervention, be it an embolization, be it what's partial nephrectomy, that is removal of the AML, but leaving the kidney behind to try to spare renal function, or removing everything, the tumour and the kidney. And what you can see, so less than 4 centimetres, about 43% required intervention. But when there are more than 4 centimetres, almost all of them required or had some form of intervention. I want to point this out to you here. This is not a good sign. In this group, 82%, when they had an intervention, had the tumour and the kidney removed. I leave it too late, and in this group what's happened is that they've lost the tumour plus the AML. And I mean, that was just one study, but this has really been backed up by other studies, a lot of number of other studies there, and essentially less than 4 centimetres, more than 4 centimetres, and there's a really big discrepancy between those that require intervention. So summarising what we know about the natural history of AMLs, so the risk factors are an association with tuberous sclerosis complex and size. We know that 82% of AMLs that are more than 4 centimetres are symptomatic. We know that 23% of AMLs that are less than 4 centimeters are symptomatic. And that more than 50% of AMLs that are more than 4 centimeters will bleed. And overall, a third of patients that present in the studies presented in quite extremis. And the problem with presenting in extremis is you can't do fancy things like embolizations. What you're really down to is intervening with life-threatening interventions, i.e. the kidney comes out. Okay, no keyhole surgeries there. And therefore, the major risk from all these series is bleeding, retroperitoneal hemorrhage, RPF. And you've got one here, that's where it's bled from, and this is all blood clot there. And more on this side. So what about intervening? Well, there are a number of steps you can intervene at. You can intervene when they're symptomatic, or worse still, when they're actually actively bleeding. Or we can intervene when patients are asymptomatic. The problem is we've got no trial evidence about what the right thing to do is and whether what we're doing is correct or not. So what can we do? Well, there's lots of things that we can do. Well, firstly, we could biopsy the lesion. We don't do that often because the vast majority of AMLs are benign lesions. We have done it when it's not looked completely normal. And then when there's a diagnostic uncertainty, we have certainly biopsied. That needs to be by a specialist because you're biopsying essentially a bag of blood and fat. So you can cause some bleeding. Nephrectomy, so we can remove the kidney itself with the AML. But we really, I think in 2013 and going forwards, we shouldn't really be doing this. We've left it too late. You might want to do it if we know that the kidney's not working anyway. And you might get more AMLs in that kidney. So removing it, that's a small caveat. I think what we're really looking at is what's called nephron sparing approach. Now, I deal with cancers only, and it's the expertise that I built up in cancer surgery, taking the tumor away and leaving the kidney behind. That's now I've transferred to this benign work, the AML work. But this, for the last 10 years, has been standard of practice in cancer surgery. If we can remove the tumor, leaving the kidney behind, that's what we should be doing. Okay, and we should be doing that not because we know for a cancer point of view, and this is not a cancer, remember, but from a cancer point of view, the cure rates are the same. But more importantly, what the studies have now shown is that those patients where you've left the kidney behind, as opposed to those patients that you've removed the tumor and the kidney, are much more less likely to run into problems with kidney failure in the future and death from kidney failure or from blood pressure issues. The more kidney you can leave behind, the less problems you're going to get in the future. And I can't see why that doesn't really transfer to this situation as well. So the interventions are partial nephrectomy, where you remove the tumor and leave the kidney behind, and that could be done open or keyhole or robotic. These are experimental is the wrong word. I think we'd have to be cautious with keyhole surgery in this at the moment until the experience is built up. You can freeze it. Not many people are doing that. And the next most important is embolization. Well, why embolization? Because the tumor is made out of 3 parts: blood, fat, and smooth muscle. But it's the abnormal blood vessels, because the blood vessels are abnormal because they're not supported by the tissue around them as they are in normal tissue, so they're more likely to bleed. And it's that bleeding risk which is the big risk, as I've pointed out, and therefore blocking the blood vessels is probably the right way to intervene. Well, why the QE? Well, I think this is a very uncommon tumour. And so the way not to go about it is that each radiologist, each surgeon around the country does one in their lifetime. Okay? We're really not going to get any further forwards as far as quality of the service we provide, as far as learning something and improving the intervention in the future, and as far as doing any studies to get some facts into this. Now, so what's important is that it's centralized. Now, you will be the third patient group that I work with quite closely. Because I deal with genetic kidney cancers, I work very closely with the von Hippel-Lindau, which is a genetic tumor group of patients, and I talk to them a couple of times a year. Bladder cancer, again, I'm president of the Birmingham, the West Midlands rather, support group. So I know what's going on with the kind of rare kind of tumours. And what we're at the QE, certainly, we've got the expertise to deal with these, both intervention and surgically. I think I'm going to add one caveat here, or one addition here, is that this is slightly different from the other patient groups that I deal with, in that, so let's talk about the genetic kidney cancers. The group is based in Birmingham. The national group is based in Birmingham, and so we see these patients. I see the patients a couple of times a year. So the sort of camaraderie builds up. With LAM, you're based in Nottingham, but you travel from around the country, and I think it's unfair that you'll be seen regularly in Nottingham, possibly in your local hospital, and then also in Birmingham. So in a way, we're at a bit of a disadvantage in that we provide high-end intervention, but you will miss out, I have to say, you will miss out on the sort of the camaraderie, because you'll essentially come to a massive new hospital. You saw the pictures on the first slide. You'll have the intervention. We'll make sure you're okay, but then your follow-up to save you, time and effort will be at Nottingham or at your local hospital. So, it's not something that you'll see. I'm more than happy if you want to come down to keep seeing me again, that's fine, but that's not the way we've set it out. So you might feel a bit of a difference there compared to, the excellent atmosphere that's built up here. So what about embolizations? Okay, this is a QE experience. Over 4 years, we've done quite a number, 65, or not, Ian's done quite a number, 65, 9 of them for AMLs. And that's gone up. It gets up more and more every year. What do we know? We know, generally speaking, I've shown you this before, that as the tumour increases in size, the chance of it, the chance of it rupturing increases as well. Now, what actually happens is you've got abnormal blood vessels, and sometimes, because they're abnormal, they get a little outpouching, what's called an aneurysm. And it's the aneurysm which is the most weakened bit of the blood vessel, and that's the bit that ruptures. And we know that when the aneurysm is about 5 millimeters in diameter, that's when the risk of it rupturing increases. So the current guidelines for intervention are a size criterion, and that's the AML being over 4 centimeters, aneurysm being more than 5 millimeters, and what we should be doing, as I've said, is to try to treat the tumour and not the kidney, and leave the kidney behind. So I'm only going to put one slide on the surgical intervention, because the majority really is radiological, but this is the surgical slide. So this is the kidney. This is an open operation, patients on the side, and what we've got here is, this is a sloop that's around the ureter, and that's a sloop that's around the blood vessel going in the artery, so that so I can control it. And what happens here is that then I put a bag around it, and then there's cold ice put around it to cool the kidney down, and then I block off the blood supply to the kidney, and then you essentially cut around the tumour, leaving the normal kidney behind and taking away the AML, and then you sew it up again. Take out the ice, let go of the clamp, bingo, done. What you've got here is an essentially healthy kidney here. Yeah, you've got to do a few to get it right. We know that we can embolize the tumour rather than surgically intervene. But it's not without, and we've known this for quite a while, but you get recurrence of the AMLs in up to a third. So it's not a panacea, and you might need it again. This is a UK experience. Now, embolization can be done electively, i.e. when it's asymptomatic, or acute, i.e. in the heat of battle, when the patient's symptomatic, or when the bleeding's already done. And what I've said about, this really reinforces what I've said before about if you can do it electively, it's much better. Because this is, if you look at here, this is the rupture rate once they're having an embolization. And this is the elective embolization, and the total rupture rate is 23%. This is in Leeds. A modern series in 2008. But when a radiologist is doing it because the patient's exsanguating, the rupture rate goes up to 40%. Okay, so the complication rate of your intervention increases. And this is what a rupture looks like. So that's the aneurysm, that out bulge that I talked about in the blood vessel, and that's what's happened. So it's swollen up and it's ruptured. So that's swollen up, it's ruptured, and this is just contrast, i.e. blood, which is just outside into this tumour. We're getting better and better at this. Scans are getting much more accurate. We're able to pick up much smaller lesions. The technology as far as probes are concerned and the materials is getting much better, as is the expertise. So this is from last year. So this is what we can see. And this is what's called digital subtraction angiography, where you just get much better pictures. So catheter's been placed in the groin, it's gone up the artery, the aorta, and that's gone into the left renal artery, and you just get this beautiful arterial tree. And you can see this is an all normal kidney, and then you're starting to see some abnormal vessels. Okay, and then what you can hear is, here we go, the catheter's gone down further, and then what you can do is you can go bring it right down into there and block off these little bits. This is stuff we couldn't do 5 years ago. We certainly couldn't do it when all those papers were published. It's another picture, really nice picture, coming in. And there's the AML. It is yep, you can see it. There's the AML, and you can see it really up, and you can just see the vasculature is completely different. This is normal vasculature, like a tree. And here it's just odd little dots. Those are all little aneurysms. These little dots that you can see. Does it come out? Does it project well? Good, yeah. So these little dots, those are all little microaneurysms. And those are the bleeding points, or those are the potential future bleeding points. And so in this case, it's sort of fed by this one or two little vessels that go from normal kidney to this AML, and the plan would be to try to block it off here. They don't often shrink. They can shrink, but they don't often shrink. That's because the majority of them are made up of fat, not the blood vessels, and it's only the blood vessels that you're treating. And here's one which is completely, so this is the kidney outline. And here we go on, we've done the same thing again, aorta, right side into the renal artery, gone right into these what's called segmental vessels. And here, you can start to see the abnormal vasculature within it. It's almost like a star there, a stellate star, and that could all be blocked off. This is the draining of the kidney. So this is where the urine, so we're putting contrast into the blood vessels, and it's going through the blood vessels into the kidney, and it's doing what a kidney should do because it filters this contrast medium, and then it's going into here, and that's will go down onto way down there into the bladder, and then it'll be weed out. So as I said, it's really been a great advance as far as the equipment's concerned, and therefore we can absolutely target the tumour rather than losing a lot of the kidney. It's not without its complications. So this is acutely, this is doing a scan immediately afterwards, and what you can see is this fresh white coloration is blood. Okay, so there's been a bleed immediately after. But this is 6 months later, and this was the AML, all of that. That's the bit that's not bled into, and that's the bit that has bled into. But 6 months later, it's all shrunk down. And you can see, so this is skin. This is this is the fat under the skin, subcutaneous tissue. So that's fat. That's what fat looks like on a CT scan. And it's not dissimilar to here, okay, because that's fat as well. So they look very similar. So this is what an AML looks like. You can see the characteristic has changed. Doesn't look that is different to that. So the character, not only has it shrunk, but in this particular case, the character of it has shrunk. That's what a normal kidney looks like on the other side. So, what about follow-up? So if we intervene, if we operate, or if we embolize, what should we do follow-up-wise? Well, there are no guidelines. Okay, so we have to really, as clinicians, we have to make up some sensible guidelines. And first important note is size may not be the best indicator. I've tried to allude to that with the fact that most of an AML is fat, and the fat bit is not the bit generally that's causing bother. It's the blood vessel, which is probably the smallest bit of it. And so the fact that it's a 10 centimeter AML doesn't necessarily mean that is, that's the problem bit. It's the blood vessel bit. So here we go, the vascular bit of it. So it might be that, it's the vascular bit of it by doing an angiogram, that's what we want to find out. What about fat-rich AMLs, i.e. ones that are predominantly fat and very little blood supply? Well, no amount of embolization is going to do a job to that, and so surgery might be the best way forward to remove it once and for all. This is what I've spoken about. Lots of scans are going to be required after intervention. Now, is that going to be at your local hospital? Will it be at Nottingham, where you come regularly? Will it be at the QE? In an ideal world, it would be at the QE, because, it's where we work. It's where we can ask for the exact scan that we want. But we realise that this is not an ideal world, and it involves quite often an arduous and horrible trip. And so we've negotiated that maybe we should have it done with Simon here in Nottingham. But we're more than happy to sort of cut our cloth to fit, whatever you want. So this is what we agreed in our last meeting, that after any intervention, it should be a CT scan. Sorry, we should have a CT scan before any intervention to work out the actual anatomy of the lesion, to work out the blood supply of the lesion, to work out how I will tackle it, or Ian will tackle it radiologically, and an ultrasound scan if it's cystic. And then after an embolization, probably a yearly MRI scan. CT's got radiation exposure risks to it. And if you're going to do frequent scans, you're probably better off doing MRI scans. MRIs show lovely anatomy, but they're more difficult to read, a lot more time consuming to read. So yearly MRI scans is essentially what we're saying. So who would we like to see in Birmingham? Those ladies with TSC, LAM, who've got AMLs of more than 2 centimetres, because we know they're at a higher risk of rupture. Sporadic LAM AMLs more than 4 centimetres. Having said that, there are certain caveats. So if there's only one kidney, I've already shown you there's a lot of evidence that treating it when it's small is probably better than waiting for it to get bigger, because really the intervention when it's too big is loss of that kidney. If it's multiple and bilateral, very similar reasoning. You're at risk of losing kidney function. Those that are symptomatic, and those that are so big that they're starting to cause problems with the kidney. Pregnancy is an interesting one. We know that cancer tumours and also AMLs are at risk, a potential risk of bleeding and rupturing in pregnancy, because of all the, well, we don't really know why, but it's presumed because of all the physiological changes. And so, that's a really important question. There's not much literature on this whatsoever. But but it's a pretty big risk. Well, we don't know. It's difficult to quantify it really. So this is something that we need to, to really find out a bit more about. I don't think we can skip that one. I don't want to put too much into this. There's that recent Lancet article, but there are certainly a number of medications out there, new medications out there. Sorry, I'll take a step back. Old medications where a new indication has been found to use them. So rapamycin, that's been around for years and years. That's been around to treat organ rejection in transplant surgery for decades now. And what this trial showed was that giving rapamycin, this is each individual patient, what happens to the AML? Well, they get smaller. They get smaller, but then when you stop the treatment, they get bigger again. And again, same here. So they get smaller on treatment, but the problem is it increases, that they increase in size when you come off treatment. Now, the problem with these trials is that, there's no doubt that the AML gets smaller, but they weren't powered to answer. The problem with AML at that kind of size isn't its size, it's the bleed risk. And there's just no data on that in the studies about whether being put on this tablet, which has got its side effects and is not cheap, actually decreases the risk of bleeding. That is the bottom line for an AML. So what about future? Well, there's a lot we know, but there's a lot we don't know. And by concentrating minds and concentrating experience, we're hoping with time, we might be able to start answering some of these gaps in our knowledge. How best to treat? How often to treat? How to follow up? All of these things we don't know, and hopefully we'll be able to answer that more with data rather than just intuition. And we know that just with radiology, surgical technique has improved massively as well. So with small tumours, they're now often done at the QE, small cancers often done at the QE with keyhole surgery. Now, I don't think we're there yet with angiomyolipomas because of the bleeding risk, but it won't be, it'll be a matter of time before we do get there. What about using both? An embolization to block off the feeding blood vessel into it to make surgery a little bit easier and requiring less blood transfusion afterwards. What about robotics? It's all coming on, and I can't see any reason why this can't be applied here. I think that's all I want to say. Thank you very much for listening. I'm happy to take any questions.
Thanks ever so much, Ruth, for doing this. We're a little behind time. Are you going to be around at lunchtime? Okay, so we got time for a couple of questions now then. Harry?
Hi.
Can you show us exactly where the kidneys are and what sort of pain would you think is associated with AML?
Okay, so AMLs often will not have pain. The only time they tend to have pain is when there's been an acute bleed in them. And then it's quite a non-specific kind of pain. The kidneys are right up in here, sort of under your rib cage on both sides. So it's in the flanks. Okay. And right at the back.
Do you expect the pain to be?
Yes. The problem is that lots of people get backache. Okay? And so trying to say that a pain from an AMLs, I would say AMLs almost certainly don't get pain. Just like cysts or cancers. Hi, you had a question?
I was diagnosed with LAM last year through going into A&E with the
There are different. I mean, I'd have to see the report. There's not another word for it, but there are certain different types of AML, depending on the components. And so I don't know if that's what they were talking about, really. AML is usually a diagnosis made on scans because it's almost, what we call pathognomonic, i.e. it looks so distinct that you'd call it an AML. The majority would. An unusual looking one. Yeah, that would be, yeah. And also, if there's been a bleed as well, that changes the look of the scan completely. Yeah.
If we have sporadic and demonstrated the incidence of tumours is actually lower,
Yes.
should there be any specific surveillance pre-treatment angiomas?
So we've agreed that you have imaging, yeah. So we've agreed that there is going to be a routine imaging, yes, and so if the ML's about 4 centimeters, then it's going to be more, you'll either come down for an opinion, and I'll look at the scans, discuss the case, or have more frequent scans, so yearly or something like that. They are quite small, slow growing. If it's a 1 centimeter or something like that, then I don't think you necessarily need scans every year.
Yeah, and that's what we've been sort of
Yeah.
doing really. So
Yeah.
it's the tumours, so the LAM tumours are small, more than about 4 centimetres. We'll do a scan probably once a year, or if they're tiny, maybe every couple of years.
Yeah.
And then if they're bigger than that, I phone up Rupesh. Sometimes we'll just scan them every 6 months and warn the patients about symptoms. So it's tailored to the size of the tumour. Not everybody does it in the same way, though.
Yeah.
Does that CT or
Probably not CT.
Well, I'll always do a CT as the first test
Yeah.
because it helps me see other LAM complications in the abdomen. But then when I follow them along, I'll usually, if it's just to measure it, if you can measure it easily, I'll do an ultrasound. If I can't measure it very easily, then I'll do an MRI scan because there's no radiation for those. But would you agree with that?
Yeah, I think that's a sensible way forwards.
So if you've had an AML in one side, did you get that right that really and truly the other side shouldn't be affected? Or is there still a possibility that you could get an AML in your other kidney?
So with sporadic, they tend to be one-sided. Tend to be. There's no. It's medicine, unfortunately. There's no guarantees, but you should be surveyed anyway.
Right.
Okay, so it should be surveyed. Now, if there's nothing in that kidney, it's very unlikely that within a year or two anything significant is going to occur. So if there's absolutely nothing in that other kidney, then you probably don't need. You probably need something every few years, possibly. They don't.
Having something every few years,
Yeah.
just to keep it.
Yeah, I agree. Yeah. Oh yes. Hi. Yeah.
I haven't heard of this with the kidneys before. Is there a link if you've got cysts in your lungs? Is there a possibility then that you can get these AMLs in your kidneys?
Yeah.
Is it quite simple?
No, so it's an association.
Right.
So yes, absolutely, it's associated.
Right.
So sporadic LAM, up to 50% of ladies will have AMLs in their kidney if you scan them. TSL LAM, almost 80%, almost all of them will have these lesions. They don't have to be big, they could be really small and subtle. So yeah, it's an association. There's a genetic element to all of this. But, yeah. Okay, thank you very much.
Giving up your Saturday.
And I remember the other person I want to thank is Sharon, who's given up her Saturday from the LAM Centre. The LAM Centre nurse, and just come along, and if anybody wants to talk to her, please. Help you.
Thanks very much, Rupesh. That was great. Zal, Rupesh is going to look at your poster. Would you like to just have a chat with them for 5 minutes. Okay, that'd be great, actually. So we have our own angiomyolipoma experience from the LAM Centre. We have a post-front at lunchtime, and we're just picking Rupesh's brains about it a bit. We're a teeny bit behind, as usual. Okay. Right. Okay. Yeah, we're a bit behind as usual, so I'm going to go through this reasonably quickly. So as most of you know, for the last few years or so, we've been doing a clinical study to see if this drug doxycycline might slow the progression of the lung problems in LAM. And the study was funded by LAM Action, by a grant from the British Lung Foundation, a little bit by the Nottingham Respiratory Research Unit, and also by a donation from the Jaron family in memory of Mary Jaron. So the clinical question that we're sort of trying to answer really is, how can we prevent the decline in lung function in women with LAM? So this is a CT scan from a patient with LAM. So this would be bottom here where the patient's lying on the table. So you're looking at a cross-section through the lungs here. These are the two tracheas. This is the right lung, that's the left lung. And you can see that in some areas there are these black holes. These are the cysts that we keep talking about. These are areas of damaged lung. And this is a patient with relatively mild disease, so probably just after diagnosis, this person would have not too many symptoms, fairly normal lung function. For some patients, and this is very variable, as I was stressing in the talk earlier, in some patients, LAM can progress where the cysts build up to a large degree and cause a big impairment in lung function. And this is a patient who was being evaluated for a lung transplant procedure. And you can see that the cysts have replaced most of the lung tissue here. And so what this represents is, over a period of years, the lungs being progressively damaged. And what we're trying to do, obviously, is take patients at diagnosis that have actually quite well-preserved lung function and try and prevent them progressing to this situation where lung function is quite badly impaired. So the mechanism by which this happens is not completely sorted out, but what we think happens is that when patients have LAM cells get into the lungs and they produce enzymes called proteases. Now, proteases are normal body proteins that everyone has, but in certain lung diseases, you produce more of these, they become activated, and instead of doing a normal job, they damage lung tissue. And if they're there and active for a long time, lung tissue gradually builds up over time. And we think that it's tissue gets damaged in LAM. And the proteases that we're particularly interested in our research group are a family of proteases called the matrix metalloproteinases, and these are present in high levels in the lungs of patients with LAM. This little picture here is a technique called in situ zymography. On the panels on the right, these white dots, these are all cells in the lungs, and these lungs look reasonably abnormal. They're from patients with LAM with slightly more advanced disease, and you can see a lot of cells in the lungs here. The panels on the left-hand side, the lighter areas represent protease activity. And in a normal lung, you'd hardly see anything. But in these lungs, you see lots of white areas, which is active proteases, particularly on the cells lining the areas of LAM here, showing that these proteins are active and they're probably destroying lung tissue slowly over a period of time. So we think this is how this happens. And you can actually measure increased levels of these proteins in the blood of patients with LAM. Each one of these dots is a patient with LAM, and we've measured the level of these matrix metalloproteinases, and there are a lot of these enzymes, but this is MMP2 and MMP9, some of the common ones, in the blood of patients with LAM. And these flat bars are the average value for LAM. and this is the average value for women without LAM, and you can see that on the whole it's higher in patients with LAM. So we think that this is what causes lung damage in LAM, and so we're interested in seeing if we can block this. So just to look at this in a little bit more detail, we think LAM arises from when a genetic mutation in a certain cell type allows the cell to behave abnormally. And we know the gene is called TSC2. It's the same gene that causes tuberous sclerosis. You get a LAM cell precursor. You need 2 mutations to turn it into a LAM cell. When you get 2 mutations, this gene stops working properly, and it allows the cells to proliferate abnormally, so you get more of them. And it also allows them to spread around the body. They get into the blood system, they get into the lymphatic channels, and then via chemical signals they get targeted to the lungs, and they get targeted to the kidneys to make angiomyolipomas. So what happens in the lung disease is then the LAM cells proliferate, they form these nodules, they make these proteins that damage the lung. And we think that if we block these MMP proteins, we could perhaps block lung damage somehow. We might even block the LAM cells that get into the circulation. So we were hoping that we could attack LAM on 2 fronts, perhaps by blocking these proteins. So I was discussing this about 5 years ago at this meeting, and I sort of thought, made me think actually afterwards. I had to be very careful what I said at this meeting, really, because I was saying that doxycycline, which is a commonly used antibiotic, can actually, as a side effect, can block the action of MMPs. And doxycycline is easily available. It doesn't have a lot of side effects. It's not a very toxic drug. It's cheap. And I was wondering if it could be potentially helpful for LAM. And as I was sort of saying this out loud, there was a sort of change in the audience, and everybody sort of rose up and said, well, you really should do a trial. Just get on with it. What's stopping you? I said, well, I haven't got much money. And they said, well, that's not a problem. And LAM Action had the biggest fundraising and most successful fundraising campaign they'd ever had. They raised £50,000 to help fund the study in a 6-month period. And so a clinical trial was born. And so I'm going to be very careful what I say in future, I think, at these meetings. But
it's because they have the mutation. So do LAM lesions contain fibroblasts? This is an interesting question because there's something of a precedent for this. Cancer cells, they recruit fibroblasts, and fibroblasts surround the cancer cells in this kind of protective stroma that affects the way the disease progresses. So they have an important, in that disease, these recruited fibroblasts have an important role. So what we want to know is that also true in LAM? And also, we need to know if there are fibroblasts in LAM nodules because we're going to make a LAM nodule in a dish, and we need to know if we need to include fibroblasts in that. So we had a look using some other antibodies that picked up specifically fibroblasts. Is this a pointer? Is something bad going to happen? It's not. It's a TV remote control, isn't it? Okay, so in the middle of the section, there is a LAM nodule. It has a fairly typical appearance. These are 3 different markers that other people have used to find fibroblasts, and we find fibroblasts in LAM nodules using these markers. So we're reasonably confident that a lot of the cells that are in a LAM nodule are actually just these recruited, completely normal cells. What we want to know is how many different populations of cells are in there. And to do that, what we need to do is look at the same piece of tissue with different antibodies at the same time. And the only way we can do that is using a technique called immunofluorescence. Immunofluorescence lets us put differently coloured antibodies on and then just look at one of them at a time, because we set the microscope to only be able to see blue or red or green. And then we can put all those images back together. On the far left, we're looking at nuclei. Each cell has one of these. So we stain them blue and we can see how many cells we have. The next 2 images are an antibody which has been dyed red and another one which has been dyed green. And using these antibodies, we can look in real detail at a LAM nodule. So this one is it's circular, and you can see within the circular nodule, there are cells which are staining bright red. They have one marker. What we need to know is, are these the same as the cells here, which are staining green, using a different antibody? And in order to know that, what we have to do is put the two images together. So we have a look and we say, does the red dye overlap the green dye? And if it does, we'll get yellow. There's actually a little cell over, which is not part of the nodule, which is over on your far left, which shows this yellow colour. So we can look in detail at the nodule. If we put the nuclei on, we can see individual cells now. So those are all the cells within the nodule. And now we know that there are at least two kinds in there. There are some which are staining with our green antibody, and there are some different cells which are staining with our red antibody. And if we look in much further, we can see the arrangement of these cells. We see there are very few red ones, and they're disseminated amongst all the green ones. And what we need to do is make this, exactly this, in a dish. So this is what we know so far, that a LAM nodule is a community of cells. It has different cell types in. All these cell types can contribute to the properties of LAM. So there are some questions that we need to address using the approaches that we have at the moment. Where do these cells come from? We don't know. They could be resident in the lungs. They could be coming from the circulation. We don't know where they come from. We don't know what type of cell they are, but we suspect that in there are lots of fibroblasts, which is interesting. There may be other kinds of cells in there, and different patients may have different compositions of their LAM, which means that the disease progresses differently in different people because these cells have different properties. How do they get into the lesion? What is it that draws them into the lesion along with the LAM cells with the mutation? There must be some mechanism for getting those cells in there. Do they actually protect the LAM cells in some way? Do they cause the LAM cells with the mutation to proliferate more? Do they make them survive when conditions get tricky, which is the kind of thing that stromal fibroblasts do in cancer? They have a protective effect and they increase the progression of the disease. Is this what those fibroblasts are doing? And how do they contribute to the destruction of the lungs? We know that we think that proteases are involved, and often proteases need to be activated. So now if you have two different cell types there, it may be that one cell type produces a protease, the other cell type activates it. So together the cells are much more destructive because now you have a much more active pathway for breaking down the lung tissue than if you had just one cell type alone. So you have this catastrophic combination of cells that is suddenly so destructive to the lung architecture. These are the questions that we want to address using our model. So we're going to make LAM nodules in a dish. When I give the talk at work, I call this talk a novel in vitro model of LAM. We need LAM cells to do that. We haven't for very long had the opportunity of getting cells from lungs. And we quite often used to use cells from angiomyolipoma, which I've talked about before. But now, occasionally, if someone has a biopsy, and I'm around in theatre, and all the paperwork and the consent is in place, I can have a little snick of excess tissue from the biopsy, if the surgeon is willing, which I then rush back to the lab. And this tiny little piece of lung, which contains the lung cells, I digest with enzymes, release all those cells, and then plate them in tissue culture, and they will grow. So we can generate cells from any little bit of tissue that we can get hold of from LAM patients. And we're very grateful to the patients who've consented for us to have their tissue. So these cells grow, they grow beautifully in culture. What they are like, sorry, it's going to go dark. They're like the fibroblasts that we spend hundreds of pounds buying in from a company. NHLF, which is the bottom panel, is normal human lung fibroblasts, and we buy these to use in our experiments. To all intents and purposes, the cells that I'm getting out of LAM lungs are identical to these cells, which again, it supports the case that these are fibroblasts. And these cells you see here at the top came from a lung from a lady who had a lung transplant, and this was her lung, and it was supplied to us by an American company called the NDRI. And we were able to generate masses and masses of these fibroblasts from this lady's lung. So we're going to make lamb in a dish. The first thing I do is I dye the cells different colours. I like to dye the fibroblasts green, and the other cells, no research lab has been able to successfully grow cells with a TSE2 mutation from lamb lungs. So essentially no one has had proper lamb lung cells to work with. And what we use instead is a cell derived from an angiomyolipoma, which should have the same lineage, and it definitely has the mutation. These are called 621 cells, so you might see that in some of the subsequent slides, and 621 cells are our lamb cells. So what we want to know is, if we put these two cells, the fibroblasts and the lamb lung cells together, what happens? Can we make a nodule this way? Do the 621 cells recruit the fibroblasts for us, which is what we think is happening in vivo? And the way we do this is we mix the cells in with a substance called collagen, which is like the matrix that they'll be growing in your lung. And it just makes the whole thing a little bit more physiological. So we mix them to get cells together. We give them a few days to do whatever they're going to do, and then we have a look to see where the cells have gone. And what happens is, these were imaged from collagen, so they're actually embedded in a gel. If you look at the top panel on this side, so your right-hand side, you can see 3 nice green fibroblasts, bright green. The next panel shows you where the 621 cells are, and they formed like a little nodule. And when we superimpose those 2 images, you can see the fibroblasts are surrounding those 621 cells. These cells have aggregated. They've naturally stuck together. They're self-aggregating. There's another example in the bottom row of panels. A whole load of fibroblasts are intermingled, which are green, are intermingled with the 621 cells, which are red, and formed essentially a nodule in a dish with no other intervention other than just letting them grow together, which does suggest that there is a mechanism for the 621 cells recruiting the fibroblasts, which is what we thought might happen. And this is a system we use to look at this in a way where we can measure the effect and also mess with it a little bit. This is called a transwell migration assay. What we do, we put the fibroblasts in a little well, hanging in a tissue culture dish. And in the bottom of the dish is tissue culture medium, which is fine. The cells are quite happy like that. There are holes in the bottom of the well, and the fibroblasts, although it will be a bit of a squeeze for them, can get through the holes. In the bottom of the well, we put something that we think the fibroblasts might like to migrate towards. So lamb cells, or even just medium from lamb cells, or even just a compound that we think they might be attracted to because we have a hypothesis that it might be one of the things they like. And then we give them a while. We just leave the fibroblasts in there. If they like what's in the bottom of the well, they can get through the holes. And then instead of being on the top of the well, they will be underneath. They'll crawl through the holes, they'll squeeze through, and they will end up stuck to the bottom. And then all we do is we say, okay, how many cells are stuck to the bottom of the well? And this is a measure of how much those cells really wanted to migrate through those holes. In a recent experiment, what we did was we put medium, tissue culture medium that 621 cells have been grown in, into the bottom of the well, or we put just normal medium. What we're thinking is that the 621 cells are making a signal, and the signal is telling the fibroblasts, come here, stick to me, and form this protective thing around me so that I can survive better. And if that's happening, the 621 cells should be able to pull the fibroblasts through the pores, the holes in this well. And if we look on your right here, you can see the cells that migrated through those holes. If there was just normal medium in, there's always a few that go for it for no good reason. But so you get a few cells come through the holes. When we have 621 cell medium there, 4 times more cells come through. There's something that those cells are producing that is pulling the fibroblasts through those holes. And it may be the same thing that's causing those two cell types to stick together when we mix them with collagen and grow them together in collagen. So using this assay now, we can investigate that process because we have hypotheses about what these factors might be. And there are drugs that can interfere with that process. So now we can say, we can test our hypotheses and we can try to stop the LAM cells from drawing in these fibroblasts. So this is what our model is for. We want to know what the mechanism is by which these cells migrate and which drugs disrupt this. It's a very simple assay to do, and we can test a whole load of drugs, even empirically, to see if they disrupt this process. We have a collaboration with a company that likes to test novel therapies in model systems like this, and they're interested in LAM, and we've tested therapies for them before, but we can use their drugs in our model as well. We can come back to estrogen. No one has found an explanation, really, for the role of estrogen in LAM. No molecular biology or cell biology explanation. But now we can say, okay, is estrogen affecting the fibroblasts? Is it making them more migratory? Is there something in this process that is estrogen dependent? We can see if the two cell types affect each other by making each other more robust, more able to survive, more proliferative, because most of the cells that seem to be proliferative in a nodule seem to be the fibroblasts. And the last thing, obviously, is the critical thing. What we need to know is this why LAM cells are so destructive? Is it this interaction, this community of cells, which all together, you have this synergistic effect that results in just much more destruction than you would have if you had just one cell type on its own? So those are our aims for this model. And what we want to do is look at all these processes, because every single one of these, the migration of the cells, the recruitment of the fibroblasts, the signaling between them, these are all potential targets for therapeutic intervention for LAM. So finally, I would just like to thank LAM Action, who fund me, all the patients who've donated tissues, and also the surgeons who've allowed me to take tissue. And Mondo Biotech funded some research a year or so ago, and the NDRI have provided us with LAM patient samples as well. So thank you very much. I'll be allowed.
Yeah. Okay. Thank you, Debbie, very much. I should have said that Debbie is the LAM Action Research Fellow, but hopefully you know that. But apologies that I didn't say that. Okay, it is lunchtime. As Jan said, there is paper and I think pencils on the tables. So if you have questions that you want to write down, we'll go through those at the end of the day. Raffle tickets, Christmas cards, merchandise, socializing, lunch. We are about 25 minutes late, but if you aim to maybe be back by 2:15 into this room, that would be great. Thanks.
Hello. Are we all here? Oh, yes, yeah. If anybody's not here, can they just say so? Good afternoon. I hope you all enjoyed lunch. Those of you who will have been involved with LAM Action before will know that this is a group that marches on its stomach. My name's Charlotte. As the more observant of you will have noticed, there is no Claire. She sends her apologies. She's not very well today. So I'm here on my lonesomes. I was diagnosed only about 2.5 years ago with LAM and have only just become involved with LAM Action, which is why I'm here, because I can say with no trace of ego, you are amazing. You are truly amazing, and this year you've been amazing for an entire decade. For me, for many of us, I suspect, LAM Action has meant sanity. I am very aware that we are standing on the shoulders of giants. We are benefiting from more than a decade of hard work, generally speaking, by other people, some of whom are here today, but many of whom aren't. So first, I wanted to start with a round of applause for the hard work, so that we can celebrate the hard work of absent friends. Now it's going to get really impressive as my glamorous assistant is going to, because I'm incompetent, is going to do the slides. So, slide one. Okay. In Britain, we're not very good about bigging ourselves up, so we're trying to buck that trend this afternoon. This is a quick trot through what we've achieved so far. LAM Action is there for us. 220 of us at the last count. There's the LAM line, the LAM post, the website, and perhaps most importantly, our coordinator, Jan Johnson. We would be nowhere without this woman who allegedly works part-time. If she works part-time, I'm a Dutchman. She is fantastic, and I think we all know that, and probably don't say it enough. So wherever she is, and I can't actually see her, which is possibly because I've got my... She's not here. It's possibly I've got my reading glasses on, so I can't see further than that. I think one of the main reasons that LAM Action is so effective is Jan. Now, this is how much money we have raised, or you have raised, because I haven't really been here, which is an incredible amount of money, particularly when you think how many of us there actually are. And these are the amazing uses that we have put that money to. Check out Simon Johnson there. Look what we've done to the man. Along with Jan, we rely on Simon and Debbie, and before them, Anne Tattersfield. We are incredibly lucky to have doctors with expertise and senses of humour. I think we should just take a moment to appreciate that. Now, Rapper. Lots of you will know of it. Some of you will be on it. LAM Action helped out at the very start. And then Doxy. Things don't always go to plan, as Simon pointed out this morning. But LAM Action funded the trial. We didn't get the result we wanted, but hey, better to know. And it just shows what we can do when we put our minds to it. Guidelines. To me, this sounds really tedious, but actually it makes a genuine difference for patients all over Europe on how they are spotted and then treated. The fact sheet. For most of us, it's the first we actually know and probably understand about the disease we've just been told we've got. Recently relaunched for the digital age, as part of LAM Action's new image, it's an incredibly useful resource and a very quick way of explaining to your GP just exactly what is wrong with you. Three rooms in Nottingham. Who would have thought that 3 rooms in Nottingham could have such an impact on our lives? The National LAM Centre, changing lives for the better. And we're live again today after some effort on everybody's part. It's just a shame we haven't worked out yet how to transmit lunch into everybody's homes. But this means not only that you can go back and look at what people said when you were zoning out, but also for people who can't be here today, they can still get hold of the information. And finally, us. This group started out with 43 members. As of now, there are 131 of us. Now, just looking at those figures really underlines how amazing all this is. 100 or so women with a disease that few people can pronounce, let alone understand, supported by family and friends, and look at what we have achieved in just 10 years. So if you can be upstanding, if you've got the energy, and I think it's time we sang happy birthday to ourselves. And I'm going to ask Jan. Oh, right. Not that they can admit in front of Simon, no. Interesting. Charlie's going to start the singing, because if I do, you'll sue me. Oh, we have a lighter. It's not much. Oh. Notes are being taken.
Absolve myself from any. If the sprinklers that the porter said I'm allowed to do it. So you've all heard that.
So once Charlie has lit these, where are the sprinklers? And then, Jan, if I can ask you to cut the cake as the woman who keeps us going, I cannot think of anybody more appropriate.
I would like to invite Anne and Simon down to blow the candles out then, please.
Okay. So here we go.
As
I was going to say it's bandage
here
on.
since we started this, because they're
Okay.
here, so.
Come on then, let's all start singing.
So if Simon and Anne can come and blow the candles. And Jan, you just do a ceremonial cut. It is really beautiful, but hey, we're going to eat it, so thank you. So, what's next? Those of you who know LAM Action know that there's no chance of resting on our laurels. What's next is the STAR campaign. You may have seen the leaflet hanging around. The idea is pretty simple. We want to raise an additional £75,000 over the next 3 years. The money will support research in the shape of a LAM Action PhD student programme. So real money for real tangible benefit. We need marathon runners, cake sales, bucket shakers, sponsored silences, people to find Freemasons. Any skill anybody has that can raise money is what we need. And also, I think perhaps we need to think a bit more strategically about people who can help us raise money. For instance, match funding from your employer, or finding out if your employer or the local school has a charity of the year and trying to suggest us. Also, maybe targeting women's groups. This is a disease which pretty much only affects women. We are women, we need money. Maybe if you know a local soroptimists, they might be interested in supporting us for a year. I am particularly bad at raising money. I don't like doing it. I find it awkward and embarrassing. So I sympathise with those of you who are, at the moment, finding your feet really interesting. But we really need to make this effort. And if I can do it, then sure as hell you can too. The other thing is rags. I didn't even know that Rag Week meant raising and giving until I read this from Kelly. I just thought Rag Week was getting drunk. But the local university or college might be a good place to start, even just to inquire, you know, just a phone call, even if they say no, well, at least you tried. There's more information actually on the leaflet, but if everybody can just have a think about ways that they can raise money. Obviously, the committee will help as much as we can and will support you, but fundamentally, I know it's asking yet more of you, but we need to do this for ourselves so that we can get the tangible benefits. So, let's hope we can all be stars. Thank you very much.
Okay, I think it is time for the next session on panic attacks and anxiety, and Jill's going to lead it off.
Thank you. Well, thank you very much. Those of you who don't know me, I'm Jill Hollis, and I'm one of the committee members. But yesterday, when we were talking about this session this afternoon, they said, Jill, perhaps you could introduce panic to the meeting. Now, there's a number of ways I could do that, most of which in my head sort of remind me of Dad's Army. But that's not what we're doing today. We have got just the man to help us talk about panic and anxiety and hyperventilation. Neil Holden, who's a consultant psychiatrist, and he told Anne that panic attacks are his bread and butter. So if there is panic here, we've got just the man to sort it out. So I think more seriously, the reason that we wanted to cover this subject is that on LAM Line, our email chat group, it's a topic that comes up time and time again. And for the person who suffers from it, it always seems a little strange and unusual. And so it is definitely worth talking about, because as a group, we do seem to be more vulnerable to panic attacks, anxiety, hyperventilation. And there's some really useful sort of tips and things about that. But I thought we might start off just by, I know there's lots of us, including myself, who have suffered from one of these issues from time to time. But I had one volunteer, well, not quite volunteer, there was a bit of arm twisting. Annie was just going to give a quick summary of her experience, and then we'll hand over to Neil, sorry.
I was diagnosed 2007, but I was not really a very anxious person, but I started getting anxiety, a full-blown panic attack in January last year. It just came on. I'd had a prang in the car 3 days before, everything was sorted out, no injuries, nothing like that. And then 3 days later, my husband's birthday, we were at our favourite restaurant, and it suddenly went cold, clammy, just a terrible sense of dread, just wanting to get out of there, feeling surreal, sweating. And in the end, we had to have doggy bags, and we went home, and then it kind of went. But from that point, I was pretty much housebound for 3 weeks, dealing with the underlying reasons for it, which was memory from when my lung collapsed. But that was a trigger moment for me, and then we worked through it with techniques, which probably Neil will explain, and I'm a lot better now.
Okay. I did check with Annie before it that even talking about it wouldn't start bring it back, because sometimes that can be a problem. But Neil, can I pass over to you just to, first of all, just set the scene? Is this a sort of typical experience?
Now, Megan, can you hear me all? Yeah, all of you? Yes? I suppose the first thing to start by saying that everyone, if you say anxiety, do you get anxiety? Some people will say, no, I'm never anxious. And other people will say, yeah, I get panic attacks. The honest people about us will say that. But anxiety is something which we all get. We all have anxiety. Why do I say that? Because it's anxiety that stops us from doing ridiculous things. It stops us walking out in front of the road when there's not enough time. It stops us. It keeps us on edge. It is part of the normal process of our brains is to keep us aware. And it's linked in that sense to something which we call arousal. And for those who deny ever being anxious, the next question will do you ever get angry, or do you ever get excited? Because arousal, which occurs in anxiety, is exactly the same physiologically, bodily, in anger and in excitement. So the symptoms that we recognize as being how you get if you're anxious, flushing, sweating, short of breath, are exactly the same things as you get when you're excited, or exactly the same thing you get when you're angry. Some people say the only difference between suffering anxiety or anger depends upon the size of the person opposite you. You know, that if they're bigger than you, you get anxious. If they are smaller, you stand up for yourself and get angry. The process of panic, of course, is usually regarded as a very much more intense form of anxiety with the same symptoms. Now, I don't really need to sit here and tell you as a group what symptoms you get in anxiety, because we've all experienced anxiety. Anxiety before job interviews, exams, someone runs into the back of your car, you get anxious. And you have the symptoms of anxiety with palpitations, churning of your stomach, feeling sick, choking. Every system in the body is affected by this arousal, this process. So you think the nervous system, you get shaking, you get headaches, you feel tense, your muscles become tense, you can get pain associated with that tension in your chest. People end up in A&E with panic attacks, saying, I'm having a heart attack. Why? Because they're tensing up their chest. In terms of the symptoms that affect the gastrointestinal tract, people get diarrhea. Some people paradoxically get constipation. They get churning. And all these symptoms are perfectly normal. And we all in this room will have had them to some extent at some time. But where it becomes difficult is that sometimes these panic attacks come on in situations where you don't feel anxious. The man who suddenly gets chest pain and rings 999 saying, I'm having a heart attack, take me to casualty, isn't actually thinking, I'm anxious. Well, he may be aware of being anxious because he'd say, well, it's because of my chest. It's because I'm getting pain. And so they put the cart before the horse in that perception and don't say, I feel anxious, therefore I'm getting these symptoms. They see it the other way around. The difficulty for you as a group of sufferers, now you're the experts in this condition. Before Anne rang me up, I barely heard of the condition, and obviously you're the experts. You know how it affects your breathing as individuals. But the trouble with this is just in the same way as people's bowels are affected, people's nervous systems are affected, the chest is also affected, and people get characteristically short of breath. As I said, people who are excited get breathless because they're excited. People who are anxious get breathless. And there's nothing unusual about that. And of course, after the anxiety is settled, it will return to normal. There are situations where the anxiety can be chronic, it can become a chronic pattern of breathing. But the question is, if you suddenly get a deterioration, there's two possibilities. One is that something has happened in the current illness, chest infection that you've got coming on. But the other alternative is this could be anxiety, and that is actually good news because it's entirely treatable. Now, I don't know whether you want this, the danger of this becoming me lecturing you. How many here suffer from very clear panic attacks in their everyday lives? So a fair few. It's not a rare occurrence. And of course, you're not alone within your illness suffering this, because it is very, as Anne would obviously tell us, it's very common in people who've got asthma being a much commoner illness, but with some overlap of symptoms with what you've got, and they get it. And sometimes the typical story with the asthmatic is an asthmatic who may have had mild asthma during their lives will have a very bad attack of asthma for some reason, whatever. They've had contact with allergens or something that set them off, pollen count being high or whatever. they end up having a real crisis, coming to hospital, and they get discharged then after a few days, a week of steroids and being settled down with various medications. But of course, when they go home, as soon as they feel, for whatever reason, just a little bit more short of breath, what they think is, oh my God, it's coming back. And that feeling makes them immediately think, gosh, I better watch this. It seems to be getting worse. And as they latch upon it as a symptom, the more you think about it, the more it gets worse. And so, in a way, that becomes like a rolling stone, a vicious circle, which makes it far, far worse than it really should be. And that's the anxiety component. The more you think about it, the worse it gets. Now, associated with that, you do various things. One is you open your mouth and you start to breathe in that way rather than through your nose, or perhaps, if some of you have got severe problems, through your pursed lips, which sometimes helps breathing. So you switch from nose your normal style of breathing to one where you're opening your mouth. And with that, you tend to hyperventilate, you feel you're short of air, therefore you work harder at it, and you lift your shoulders up, and you're really pushing at it as if you've just been running a mile. And what you've got to try and do is to reverse that behavior consciously, so that you try and breathe through your nose. It's very hard to hyperventilate through your nose, but trying to do that will make you feel more in control. And if you can try and relax, get your shoulders down, drop your shoulders, drop your arms, you will also find that helps. And then the conscious approach to trying to say, well, this, I know what it is. It's not something to be frightened of, even though it is fear itself. And I need to start thinking about what else is going on. What set me off in this? What's happening to me? What else am I getting? Now, of those who do get panic attacks or who've had them, do you remember what happens to you after a little while? What does it feel like, apart from the shortness of breath? Do you get any other symptoms? It's exhausting, absolutely. Obviously, it's very, very tiring. Dry mouth from, obviously, the air passing over it. If I were to be talking to a group of medical students, I might actually set them off doing a session of hyperventilation, just for fun. And I would say to them, well, we're going to do it for a minute, and I want you to breathe. And you see my shoulders are lifting, and I've already opened my mouth. And if you do that for a minute, and then you stand up, you can guarantee the symptoms that those students, as healthy individuals, volunteers, you can guarantee what they'll get. They will feel hot, faces will be flushing. They will feel that they have a dizziness. Some of them will describe tingling of their mouths, noses, fingers, possibly feet. And this is all due to breathing off carbon dioxide. And by doing that, they make themselves less acid inside, because carbon dioxide is acid. And the result of that is they get this tingling in their fingers. And of course, when that starts happening, you start thinking, well, my goodness, what's happening to me? This is something awful. And it again accelerates this vicious circle. So much so that what we generally tell patients, as this is a psychiatrist, and perhaps it might be frowned on by others, is the classic thing is to say, get a brown paper bag. And you breathe into this bag and breathe back in from the air in the bag. Now, I would probably need to turn to Simon or Anne and say, well, I don't know what that would do to someone with LAM syndrome. Because, of course, you're not quite the same as an average person in that sense. But the danger is that by the particular pattern of behavior that you're getting into, that you're just creating for yourselves a set of symptoms which you need not have. And it becomes this vicious cycle, and all the time your anxiety is getting worse. Now, yeah, sorry.
I was just going to say at this point, because what Annie was describing was very much a panic attack.
Yes.
What I had was very much more a sort of chronic version of heightened hyperventilation, where I had got into a habit of hyperventilation.
Yes.
And I was just explaining to Neil earlier that in my case I'd had a chest infection, this was pre-transplant, had a chest infection, was going on holiday, a walking holiday, wanted to get fit, so went to the gym and probably did that classic, breathing through the mouth, and got into that pattern. My breathlessness then increased hugely, and I ended up seeing my consultant saying, I think my LAM's got really, really worse. And he turned around and said, no, it's not, but you're breathing at 60 breaths a minute, whereas you should be breathing at somewhere between 12, 15. So I had got into this pattern of hyperventilation, which is exactly the same thing, but on a chronic basis. And it was very hard to kick. So I think there's the classic attacks, but there's also this, sort of constant anxiety.
And I think that the process is very similar. It's just that obviously one is long-standing and becomes ingrained in behaviour, as you're describing. The other is shorter term, associated probably with more overt, obvious anxiety of, my goodness, what's happening to me? And obviously, the two conditions have great similarity. They have some differences in terms of how they are developed. Because, of course, when the panic attack has passed, the sufferer is back to normal, and the question is, how do I prevent another one? Or how can I be aware of another one? Whereas when it becomes chronic, the question is, what can I do about my behaviour to reverse it? I suppose that really then comes on to what can we do about it. And I suppose just as a plug for my own profession, I'm a psychiatrist, but I'm not a typical psychiatrist. What does that mean? I always feel very wary about saying typical psychiatrist, because does that mean I'm more or less mad than my colleagues? But I'm a liaison psychiatrist, which means I'm a psychiatrist working purely with people who have physical problems in a general hospital setting. And most big areas have a liaison psychiatry service, which is useful for you to know because those psychiatrists and the staff they work with have a lot of experience in working with people who have got, whatever it may be, asthma. They won't have a lot of experience in LAM because obviously they won't see it very often. But they have a lot of experience in asthma, which has very similar, what should we say, skills needed, required. They have a lot of skills in working with the principles of the problems of physical illness. And that is a resource that you should be able to tap into if you are running into problems. Now, if you're in a smaller town or city, you may have more difficulty accessing a service because it probably is not very well developed. But there usually will be a liaison nurse, or alternatively, the possibility of a referral to one of the larger centres that obviously will be associated with your respiratory care as well. So that's just a little plug. The two approaches are broadly divided into medication on one hand and to psychotherapeutic type approaches on the other. Now, when I say psychotherapeutic approaches, which of course really is the most ideal approach, I'm thinking very much about behavioural approaches. The paradox of this, of most behavioural approaches to respiratory problems come from physiotherapists who are attached to the respiratory units and who can teach new breathing patterns, trying to get regulating the breathing, dropping shoulders, breathing through mouths, teaching individuals to relax in a very basic way of relaxation therapy. And these are behavioral approaches. They're not requiring anything. They don't assume that you've got psychological problems. They are just simply trying to tackle the behavior. But people now link to it what's called cognitive behavior therapy, which is a process of looking at the thinking behind all this. What's going through your head? Oh my God, I've got a problem here. Something's getting worse. Something's happened to me. I must get help straight away. Those sort of things can be tackled as well by that approach. And then the other side to all is, well, are there medications if you are really getting very anxious associated with it? There are some very helpful medications. Some you have to avoid because of the illness. So-called beta blockers shouldn't be given because they affect your airways. But other drugs can be used, particularly in the situation maybe where you find that someone is persistently anxious, where if you can actually demonstrate that by making their anxiety less, by giving, say, something like diazepam, Valium, for a very short time, maybe just for 6 hours or something, it can actually allow them to feel free of anxiety again, as almost like an experiment. So I'm not suggesting any of you become junkies, just simply that medications may have a sensible use at times. But a lot of this is about behavior. It's about dropping shoulders, breathing through the nose, and generally getting into relaxation mode, trying to challenge that idea, oh my God, something has happened to me, what's descending upon me at this moment.
I know that at previous meetings we've actually talked about breathing techniques and had people come and demonstrate good breathing techniques, which I think goes very much hand in hand with this. The one thing that I struggled with personally, and I think it's this association with anxiety. Does that mean you're an anxious person? I think both Annie and I were saying we're not naturally anxious people.
And I think stigma, the idea that somehow I'm being told this isn't in my lungs now, it's in my head, I think is the wrong direction to go in. We all have a head, we all have lungs. The relationship between the two is something that is there with all of us. These are very complex mechanisms in terms of our breathing, in terms of what we think. We all have anxiety. Anxiety affects all of us. At times we will be short of breath because we're anxious. It happens to me. I don't mind admitting that. Before a situation like an interview or somewhere where you're put on the spot, you will feel symptoms of anxiety, which will include feeling short of breath or being vulnerable to be short of breath. It's not just the idea that it's anxiety does not mean that this is in any way your fault. And that's very important to recognise.
Why is it as a community women with LAM are more susceptible then? Is it just the respiratory disease?
I think that you are sensitized to your lungs because you are worried that, am I going to get some form of sudden decline of my lung function at some point? And that worries you so that you're watching it. Now, one of the features of anxiety is that we all become what we call introspective. When you're worried about something, say you're worried about, you've had an operation on your tummy, you think about your tummy all the time afterwards, wondering, is this gurgling something that should or shouldn't be there? Is it working right? Isn't it working right? You start to concentrate on it. Now, when you do that, it makes you anxious. It makes you focus on it. You become very aware. So you are, as a group of sufferers, probably more aware than the average person about breathing. You remember as a child that game that sometimes people try and control their breathing as a child, and when they do so, they almost forget how to breathe in an involuntary way, and so it can almost make themselves anxious. And it's a bit like that. The more you think about your breathing, the more it feels as though it's a conscious effort. That then creates anxiety for you. Yeah, no, yeah.
Well, I was just going to say that I've never had a panic attack as such, but I do remember a time when I was going for an interview or something which was obviously a bit stressful, and having to climb a flight of stairs. And when I got to the top, I was breathless, and I thought, well, normally I wouldn't have been breathless at that point. And that's because I was hyperventilating as part of the anxiety, as you've described. Now, I had normal lungs, but if you've got a limited lung capacity and you start to hyperventilate, then you just don't have the capacity to do it comfortably. I mean, so I think it is the lack of capacity to be able to hyperventilate, which is why LAM patients have a particular problem, as do patients with asthma. And the other thing, whilst we're about it, I used to occasionally get patients to hyperventilate in the clinic for a minute, not if they were very high, low oxygen at the time. But it was very useful because they'd say, yes, of course, those are, I'd say, are those like the symptoms you've been getting? And they'd say yes, and that's half the battle to, if people know it's due to hyperventilation and the vicious cycle due to getting rid of carbon dioxide, as you explained, then...
Yeah, I mean, I always find myself most short of breath when someone says, there's a phone call up in your office upstairs, and you go up 3 flights of steps, you're wondering who's on the other end, you don't want to sound as though you're sort of heavy breathing them on the phone, and by the time you get there, you're completely short of breath, and you're also extremely aware of it, that you're about to stumble over your words because you are going to be short of breath. And it's situations like that where there's this mixture of feeling you've got to perform, that question of what's going to happen to me, am I going to let myself down, am I going to collapse in some way, am I going to literally feel, am I going to disgrace myself or create a fuss that makes people far worse. And it's about trying to say, no, it doesn't matter, this isn't important. What's important is just I calm down, breathe in a controlled way, use what I've been taught in the best possible way to try and take control of the situation. But it's not very abnormal, yes.
I was wondering if it helps kind of avoiding stimulants with anxiety. So is it teas, coffee, sugar?
I think everyone is different, and just as you go to a dinner party and there'll be those saying, I want decaffeinated, and there'll be others who are saying, no, I want give me an espresso. People have their choices in respect of sleeplessness. Exactly the same way, some people find that they, as a result of having stimulants of one sort or another, will find themselves worse. And it's about trial and error. If you feel empirically you're worse after tea, coffee, and of course that's tea and coffee have vaguely got effects on your lungs, so possibly slightly positive. So it's a spin-off, isn't it, in these situations? So try it out for yourself. Do a controlled trial. See what you feel, whether it makes a difference. But certainly, some things do make you more anxious. There's no doubt about that. Some things that we do or eat or whatever will make us worse.
Yeah. I was wondering, I think quite a few people experience this intense urge to go home. They feel a sense of kind of unsafety and things.
Yes.
Or if I go home, I'll be safe. And obviously, should you sort of listen to that urge, even though you know it's irrational? Is there a way to kind of calm yourself even if you're not going home?
Well, classically, that is exactly what, if you say, well, what is the definition of panic? It usually involves an element of getting out of the situation you find yourself in. So you become sensitized to a situation. So if you've had an episode that's maybe associated with going into Asda, not that it's Asda's fault, but you have a panic attack there. When you go back into Asda, you think, will it happen again? So if it does happen again a second time, there's no way you're going to go back again. You actually then start saying, I will avoid it. Or you take someone with you, or you do something differently about it. And that, you can see how that reinforces it. Each time it happens, it gets worse. So if you find that in queues generally, you find yourself getting tight in your chest and I really can't stand being in this queue, I must get out, that will get worse each time you leave a queue, because you associate, I'm in a queue, I'm going to get short of breath, so I will leave it. And that then becomes a real disability, because we're English, we've got to queue. So, you know, it really does become a disability. So you need to try and resist that urge to get out. Yeah, it's different from about putting yourself in a place of safety when you need to be in a place of safety. But in general, if it's about a panic attack, you need to try and stick with it. Use those techniques in situ where you are, to trying to control your breathing, dropping your shoulders, breathing through your nose and thinking, I'm going to be all right, this is fine, I'm just, anxious because this is that set of circumstances yet again, I know what's happening to me.
I'm one of the people that would have said, no, yes, I worry. I'm a mother, that's what mothers do. But I would have said I don't have panic or anxiety attacks. But when I first went on oxygen, after about 6 months or so, my osteopath was, because I kept saying, oh, you know, my neck's really tight every time I went. And she said, that's because you're using your auxiliary breathing muscles all the time. So I was literally using my shoulders to breathe. And we worked out that was probably because my brain was saying, you need to breathe more because you're on oxygen.
Yes.
And so by sort of knowing that that was what my brain was saying, I could tell it, don't be stupid, I don't need to breathe more because I'm on oxygen.
And telling yourself that I'm not going to be stupid, I'm going to keep control of this, I know what I'm doing. That's what we call the cognitive bit. The breathing bits, the things that you're taught, that you work through with your physio or about dropping your shoulders, not using your accessory muscles. Use your diaphragm, get back to what you normally do. Yes, that's right. You then find that you're conquering it. And of course that is marvellous, that it gives you more enormous confidence when you can deal with this.
I must say, personally I found breathing exercises and being taught to breathe properly and was some of the best lessons I got. So it's definitely something to ask about again if any of you are thinking about
breathing exercises. When I had breathing exercises when I was first diagnosed, and just to kind of lie down and breathe from the stomach, from the diaphragm. And I find when I'm getting very anxious and I'm out, and I do find I can tell myself to slow down, to breathe from my stomach, and it takes a while to get from the head to the stomach, you know. But yes, it does help. The only thing where it doesn't help is I'm quite claustrophobic, and I can't cope with anything covering my face. So I have problems with things like going to the dentist.
Yes.
Even though I'm only going for a checkup, and I know that I'll be in and out in 5 minutes, I've still got to go in. So I must admit, my GP has given me diazepam.
Yes.
But it's just
for the dentist.
For the dentist.
No, absolutely.
An hour before the treatment.
Yes.
And I must admit, I can understand why people become addicted, because the feeling of calm is lovely.
Yes.
You know, I really can understand it. He can do anything. And I'm laying there thinking, oh, I'm sat here and I'm not upset.
Well,
but yeah, Will comes in, I don't take it all day, I just have the one.
Well, I mean, of course, you're probably aware that, a double gin and tonic will probably do the same, but then of course you might smell of alcohol. So, these are not, there's nothing magical about medication. It's simply a tool for a job, and if you need that, you've got an issue about dentists, you can either deal with it that way, or you could try and get your GP to refer you for some sort of basic behavioural counselling. The trouble is, as you probably many of you have discovered, and that is people are scared off by psychiatric staff or psychological staff are often scared off by physical things. Oh, I don't know anything about that. So,
any kind of treatment where it's around my head.
yes.
I'm just a dentist.
Yes.
I mean, you can inject me here, there, and everywhere, and I'm not going to worry one bit. But the thought of something happening around here, and we just, start to catch.
Yes.
I don't particularly know. I'm also a bit the same about lifts. A kind of small metal lifts with no gaps. I just slip it in, and if there's no way I'm going to big area was okay. Especially big, small lifts with lots of many.
I don't know, some people might find that quite attractive.
Yes, within there.
Does anyone else have any more questions for Neil?
I identify with the description of the over-breathing, the overheating, but what's the great unmentionable when you start to wet yourself, you're out catching a train to go to work and you think, oh my God, I can either breathe or pee. And I think I've got to breathe or else I'm going to die. And you're actually standing in the station at the lift, luckily there's no one near you, and you realise you're going to actually wet yourself in public. And is there any way you can stop that happening? I mean, in my case, I just have to go back home again, phone works, I missed the train, sorry, we'll be late. Didn't actually admit why I was going to be late, but just like you were talking about Asta, the next time I was going to work, I just was approaching the station and I could already feel myself, oh God, don't let it happen again, don't let it happen again, even though I'd been to the loo maybe 3 times in 10 minutes before going out, in case it happened again.
And of course...
Is there anything that you can give us tips for there?
Well, it's a common fear in panic attack that people they get a feeling of frequency, a feeling of desire to empty their bladder. If they've got a full bladder, then of course, yes, there can be problems. The thing is, it actually is less common than most people, certainly those who are frightened of this happening, imagine. And, as you rightly say, what's happened after that one episode, which has sensitized you, is that you now are fearful wherever you go of, oh my goodness, it might happen again. This isn't a problem just for people with panic attacks. It's said that when Edward VIII was given, the only piece of advice he was ever given by his father, George V, was whenever you go past a gents' toilet, use it, because you might never see one again during the rest of the day. And in a sense, having an empty bladder, as you rightly have found yourself, is an extremely good way of controlling this, because you will still, even though you might only have a teaspoonful left of urine, you'll still get the sensation of, oh my goodness, I'm going to have an accident with it. But you've left the house having emptied your bladder. You've not had 3 cups of coffee before you've left because you're sensible. And so actually there isn't anything there. It's just a sensation. Were you, and this gets terribly personal, but were you to have a tiny accident, nobody would notice. And again, that's the other thing about this. When you actually have had an accident, we're all extremely conscious of that. And I say we all because I don't think anyone in this room has never had a urinary accident of some sort or another. And so, it's not noticeable in 99.9% of times. If obviously circumstances do occur where it might be, and that can be upsetting, but usually you don't have to go back home. And these are the sorts of things that logically you need to recognise, tell yourself, and to address in that sense. Beyond that, there is the question of what triggered the anxiety, what triggers it, is it a particular setting or a particular set of triggers, can you desensitise yourself to those triggers? So that idea, I'm leaving, I'm in a rush, I'm trying to catch a train, whatever, so you give yourself more time, you plan a little bit differently, you take yourself to stations in other ways so that you know that, and so on and so forth. There are ways of trying to plan around it. But generally, because anxiety is so common, we do know that people aren't all the time being incontinent as a result of it. It's a fear of being incontinent rather than incontinence, usually. I hope that helps.
Yes, it does. I think you were saying about address it in a different way. I think one thing that helped me was to see there was another train 15 minutes later. So actually, if I just stopped in my tracks when I was getting breakfast,
yes.
Let it go.
Yes.
Let it go. You're going to miss it. There's one coming in 15 minutes. Instead of thinking, I've got to get that one, I've got to get that one.
Yes.
So now I've got the timetable written in my diary, and I'm actually every 20 minutes to half an hour. So I try and go for the one before the one I really want.
Yes.
It doesn't matter.
And you also see how this is an experience that we have all had. That is, I've got to be there for such and such a time, or else I will miss a train, I'll miss the beginning of a meeting, I will, something will happen. You pressurize yourself, and what you get, you might say, you might recognize as I'm anxious, but equally you might just say, well, I was under pressure, I was stressed, or I was excited. And they all have the same effect. And it's about trying to recognize that there is nothing abnormal about that situation at all. It's how you then build layers of belief on top of it about that makes it something that it's not warranting.
Well, thank you very much. I'm not seeing any more hands up, but saying LAM Action, you can get everything from happy pills to cake in one session. But I think seriously, Neil, what we've just talked about is something that does affect, all of us in the room to some extent or another. The LAM patients, some of the LAM patients particularly susceptible, and even just that feeling that it's normal, just it sometimes is part of the condition. Makes us more susceptible to it. That in itself is quite reassuring, I think. But you've given us some very useful tips on how to handle it and think about it as well. So thank you very much.
Thank you. Thank you very much.
Could I just say, the raffle has been drawn. And I'm not going to announce the winners, but the tickets, the prize-winning tickets are stuck to the prizes. So if your ticket matches a ticket on the prize, you've won it.
Okay. It's the question and answer time now, which I think is especially appropriate onto the last session, one of the most useful ones. So Anne Tattersfield and Simon Johnson are going to take your questions, and hopefully, if you didn't have a chance to write anything down, but you have a question, just please, obviously feel free to put your hand up. And we'll be wandering around with a mic as well.
So, as Kelly said, if anybody thinks of any related questions or actually anything else, then please ask away. So I've divided them into sort of slightly linked things. There's a couple of lifestyles here that I thought we could perhaps kick off with. So the first question is, have there been any links made between people's lifestyles and LAM? For example, can LAM be more severe with a stressful life, bad diet, lack of sleep? Is the first question. Okay. Okay. So maybe I'll start. Actually, people ask about stress and these sorts of things with virtually every disease, and I think most people with chronic diseases, the whole thing is overlaid onto everything that happens in their life. And if people are having a difficult time, obviously health concerns are part of that. I mean, we don't know of any particular links of can stress make LAM worse, or can lack of sleep make LAM worse, but actually making your life more difficult obviously will impact upon having a condition. Bad diet, again, as a general measure for women with LAM, we always recommend that people have a healthy mixed diet and try and keep an ideal weight, which will help with breathlessness and exercise performance. But other than that would be the general advice.
No, I mean, there's no evidence that any lifestyle factor affects the causation of LAM, nor the rate of progression of LAM. What it can do is alter your symptoms, because, as we've been hearing, if you're very stressed, you may be more breathless because of that. So it can alter your symptoms, but it doesn't affect the underlying LAM. I'm sure it's highly unlikely, and there's certainly no evidence that any lifestyle factor will affect the underlying process that's occurring in LAM. The next is, does the fact that I have never taken the contraceptive pill have any impact on my progression with LAM? My LAM is relatively mild. The very first study we did in LAM was about 17 years ago, or something like that, before 10 years, was a questionnaire study, and we didn't have a lot of patients, but sort of, it was what's called a case control study. So we tried, the question we were asking was, is the contraceptive pill related to LAM? And certainly the finding was that it was not related to people developing LAM. As far as I don't know, the progression of LAM, there's been a...
There was another study that a group from Florida did, actually, and they compared women with LAM who'd taken the contraceptive pill and those who hadn't taken the contraceptive pill in the past. And again, it was a small study, but actually the people who had taken the pill, their LAM came to diagnosis about 3 years before the patients that hadn't taken the contraceptive pill. So the authors concluded that possibly it had maybe speeded things along a little bit. And certainly we do advise women with LAM to avoid any treatments with estrogen in them, which would include the combined contraceptive pill, hormone replacement therapy after the menopause, that sort of thing. So having not taken the pill may well be a good thing, but having taken it probably wouldn't have made a huge difference, providing it's in the past.
What can we do to keep our kidneys as healthy as possible long term? Alcohol, fluid intake, BP control. Well, you should have a reasonably good fluid intake. I mean, a normal fluid intake. I don't think you need to go to excess. It's not good to have too little fluid. It's not good to have too much fluid. So just, well, 1 litre to 2 litres a day would be fine for a normal person with fairly normal kidney function to start with. And if you had kidney problems, what was called renal insufficiency, kidney function not working properly, then you need to get advice from the doctor who's made that diagnosis. I think the kidneys are one thing that alcohol doesn't affect, by and large anyway. No good evidence that alcohol will make any difference to the kidneys. Blood pressure control is very important for kidney function, and if you do have high blood pressure, then yes, for all sorts of reasons, that should be kept under control.
Yeah, I mean, I just guess just the thing to highlight really is that the angiomyolipomas that half of women with LAM have don't usually affect kidney function themselves. So even if you have one of these angiomyolipomas, there's no real reason why why your kidneys would become damaged longer term. Obviously, you need to deal with the angiomyolipoma, but actually how the kidney works, unless it's a very big tumour, it isn't usually affected. So most women with LAM don't get problems of their kidney function as such. Okay. Should women with LAM who have no previous problems with their kidneys have them regularly scanned to keep an eye out for AMLs? So we recommend that when patients are diagnosed with LAM, then that they have their abdomen scanned to determine whether they've got angiomyolipomas. And even if you've had no symptoms at all, sometimes there can be an angiomyolipoma there that requires something doing. And as Rupesh highlighted earlier today, if the tumours are big, we scan them quite often and consider treating them to prevent complications. If they're small, we just make sure they're not growing. So the answer, so this question, if you have a kidney scan and you don't have an angiomyolipoma, can you just forget about it? You probably can for a good long time. I'll repeat kidney scans. If somebody hasn't had their kidney scanned for 5, or longer years, I might just repeat the scan just to make sure nothing else has sort of appeared over that time, especially if the disease seems active in other ways. So I think if you've had a baseline scan, you don't have a kidney tumour, you can sort of put that sort of worry to one side for a good long time. It may well be, if your symptoms change, you should perhaps have another scan in a few years, if it's a little while since they've cropped up.
For someone with severe LAM, is it okay to have gentle massage, maybe to help reduce anxiety? Well, I'm not quite sure what's involved, but I would have thought absolutely yes, and try it and see. I mean, if you were to get more breathless, then obviously sort of stop it, but I can't. I think I'll stop there.
I didn't write that question, but I think it might relate to something that was on Landline months and months ago about lymphatic drainage massage, because some patients had it and some patients didn't, and there was, I think, a debate as to whether LAM patients, if it was endangering them in any way to have lymphatic drainage massages. I don't know if that's the point of it, but
I've never heard of lymphatic drainage lavage. How do you do it?
I don't know.
Does anybody know?
I was just going to say, that was my question. It was more, is it okay to have gentle massage?
Yes. No, I mean that's a good question. I just don't know what lymph. I mean, I can see if you've got sort of, the problems that people sometimes get in Africa with lymph, blockage of the lymph vessels in the leg, you might be able to massage, but I don't know how you massage the abdomen, which is where.
Yeah. Is it like, I think it was the query was, is it like spread the LAM cells around the floor?
Just doing general massage.
Yeah, I guess it stimulates the lymphatic system, or that's what they purport that it does. And is that a bad thing to potentially be spreading the LAM cells more?
It sounds highly unlikely to me. I mean, you can't say no because nobody's looked at it, but it's not something that would have been top of my list of things to avoid if I had LAM. Right.
Usual. This question, does air travel have any effect on LAM and patients? Lots of women with LAM get told not to fly, actually, because they get told that it increases their risk of having pneumothorax. And certainly there are a couple of reports of people getting into trouble on flights because they have a collapsed lung. And I think if you look at those reports in detail, most of the people that have run into trouble probably had the pneumothorax before they got on the flight. It wasn't that they got on the plane and that caused their lung to collapse. It was that they probably had a pneumothorax, which 3/4 of women with LAM will have at some point. If you get on a plane with a pneumothorax, as the plane goes up, the plane's pressurized to about 10,000 feet, which means the pressure when the plane's at its cruising altitude isn't as high as on the ground, which allows the pneumothorax to expand because of the pressure change, and that will squash the rest of the lung, and that can cause problems and symptoms. If you haven't got a pneumothorax when you get on the flight, it's in my mind fairly unlikely that the pressure change would cause one, although that's always the concern. The American group did a big survey of this, and it was a retrospective survey with all those sorts of problems. But actually, problems with breathing for women with LAM on flights were actually pretty uncommon. I think about they looked at a lot of miles in the air with a couple of hundred patients. I think about 2% of flights had complications, and sometimes that was breathlessness due to low oxygen, because as the pressure's lower in a plane when it's at cruising altitude, the oxygen tension's lower. And 1 or 2 were due to pneumothorax, and as I say, those were probably pre-existing ones. So I think for most people, if they've had a pneumothorax and it's resolved completely, it's probably okay. And if their lung function's not too bad, it's probably okay. And if their oxygen level is low most of the time, your doctor can check beforehand if it's safe for you to go up in a plane and be exposed to the slightly lower oxygen pressure when you're up. Georgia?
Yes, this is a really difficult one, because I agree that the majority of people who go up in a plane that have LAM are perfectly okay, but because there are cysts in the lung and some of them could be closed off, the pressure will increase in those cysts. And if I had LAM, I would not get a job that involved a lot of flying. I wouldn't, if I was not too breathless, I wouldn't mind, I would do the odd flight. But I think because of the slight uncertainty here, even if it is a rare event, I wouldn't, because it's not so much the air miles. Once you're up, you're all right, it's all stable. It's the going up and down that sort of will cause problems. So fine to fly if you don't have any symptoms beforehand. And I mean, if you've any doubt about whether you've had a small pneumothorax before a flight, then you should go to your doctor and maybe have a chest x-ray if needs be. But if that's not the case and you're feeling pretty well and you're going on a flight, fine. But as I say, I wouldn't get a job which involved a lot of flying. Are there any more questions from the floor? Sorry, Lucy.
Yes, following on from the previous session. Sorry, yes, following on from the session about panic attacks. Is it, I think I've been asked this before, I'm just asking again, is it ever the case that low sats can cause incontinence? I mean, because as he was talking, I suddenly started feeling a little bit panicky, not that I need to go to the loo, but just slightly panicky. And I realised, well, not so much panicky as aware that my heart was beating faster and that I felt a bit hotter. And it's because the oxygen went out. Because I'm not checking regularly, I don't know until I actually put it between my teeth and see if it's flowing or not. So my sats were quite low. The oxygen, I was fine. I wasn't panicking. No. But I did have a change in, my heart rate.
I think a low oxygen, depends how low, but will make you want to breathe more, and so you
And if I were walking, it would definitely make me.
Yes, and I mean, with limited capacity, then obviously you will start to feel more breathless, and then you might get rid of more carbon dioxide, even though you can't actually hyperventilate a great deal more. So you would get the symptoms of panicking. Yes. No, I think that's. I mean, it doesn't happen until the oxygen sats get quite low, but yes, I'm sure yours do. Yes, I think that's perfectly possible.
To get rid of the anxiety, because even when I'm not thinking about anything bad, just because the sats get low, I start getting the symptoms.
Yes.
So I suppose I should.
Well, I think because you are so breathless a lot of the time, you're on the edge, and any increase in ventilation, whether it's for walking or just feeling slightly anxious about something, is going to make you a lot more breathless. And
Thank you.
It's good exercise taking the.
I was asked by my sister to find out if there's any evidence that taking statins alongside the rapamune that she's on could be beneficial.
So this is a hot research area at the moment. Statins are the cholesterol-lowering drugs that actually lots of people take now, and they're mostly for people with an increased risk of cardiovascular events. And they lower cholesterol and reduce the chances of heart attack, stroke, and that's why most people take statins. One of the things that statins do, apart from the effect on cholesterol, is that they affect proteins that interact with proteins in the mTOR pathway. And a couple of groups, most in the States, have been looking at whether these other proteins can affect LAM cell biology. And the evidence is a bit difficult to interpret at the moment, but Vera Krimskaya's group from Philadelphia have shown that if you take if you give LAM cells, not patients, and you give mice with TSE2 null cells that are growing inside them rapamycin, the cells stop growing. If you give them rapamycin and simvastatin, the cells stop growing and die, and don't come back. So rapamycin alone stops them growing. You stop the rapamycin, they grow back again. Rapamycin and simvastatin stop growing, don't come back. And that was a very exciting result, but it's only in models and test tubes and that sort of thing. So there was a lot of interest after that. Another group from Harvard used a different statin, a torvastatin, did the same sorts of experiments, didn't work at all. And so there's a bit of the jury's still out, but it looks there are chemical differences between a torvastatin and simvastatin, and it looks like more work's been done on simvastatin. There may be an advantage in these cell experiments. And so Vera Krimskaya now is going to do a small safety study in women with LAM to see if rapamycin plus simvastatin is better and, well, safe to take first of all, and then if that is the case, better. At the moment, we wouldn't advise people to take statins as well as rapamycin, although clearly there's a bit of that going on.
But if somebody's on a statin already?
If somebody's on a statin already, it's probably safe. And if I was going to take one, I'd probably take simvastatin rather than a torvastatin. The other thing is that once this came out, the NIH group looked at their patients who were taking simvastatin as, I think just simvastatin alone, not simvastatin and rapamycin, and compared them with their LAM patients that weren't. And there were some small differences in lung function in the simvastatin group, but that might have been due to bias. And so the data is all a bit muddly, but there is going to be a study, and we will be able to answer that question, but we wouldn't recommend people to take it just now. But if they're taking both drugs, we wouldn't recommend them to stop either. So that's where we are.
Have you noticed anything with patients
So if anybody didn't hear, Harry's just asked, have we noticed if people's lung function improved if they were taking rapamycin, then were given simvastatin for another reason? I personally haven't seen that. Not many of my patients happen to take statins because most of them are younger and they don't, on the whole, need them. But and I haven't heard that reported, but I'm sure somebody's probably sort of trawling around looking for that sort of data at the moment, I would imagine.
I'm not sure, but my doctor put me on simvastatin along with the rapamycin in order to keep my cholesterol down, because they said it's quite high. So is it okay?
As far as we know, as far as is known at the moment, yes. And if your cholesterol is high, then you have to weigh the benefits from the simvastatin, if there was any risk. But it sounds as though if anything, it's a positive.
Any chance the LAM Centre could sort of add secondary pulmonary hypertension to the things that it's doing? Because there are quite a few of us now. Secondary pulmonary hypertension who've had LAM for a long time. Well, yes, if possible.
So this question is, if your oxygen levels are low for a long time, a compensatory mechanism puts the blood pressure up in your lungs, and that's called pulmonary hypertension. And this can occur in I think probably a relatively small number of women who get LAM. And Lucy's asking if we could manage that in the LAM Centre, and actually we do screen patients for pulmonary hypertension if by echocardiography, doing an ultrasound of the heart, so you can measure the pressure in the lungs that's coming out of the heart. And we do screen that in patients who've got more advanced lung disease. We don't do that for everybody because it's really only the patient, well, it's probably only the patients with more advanced disease that we need to do that in. The way that pulmonary hypertension is treated in the UK, it's in restricted. The drugs are very expensive and need specialist monitoring, and actually only 5 centres in the UK are allowed to treat pulmonary hypertension. And so Nottingham's not one of them, as you no doubt know. So that's sort of the situation. I mean, we do look for it in the patients who might have it, but in terms of can we treat it when we find it, the answer is at the moment we probably can't, because like the LAM Centre, it's a pretty specialised thing with specialised treatments, and it's probably best left to people who do that every day, I think.
I mean, the first treatment for pulmonary hypertension is oxygen, but obviously most people are having that anyway. So, the evidence that the drugs that are being used for what's called primary pulmonary hypertension are helpful in secondary pulmonary hypertension, I think, is a bit sparse, isn't it?
And actually, unless you have a small number of defined causes of secondary pulmonary hypertension, actually they're not really allowed to prescribe you the drugs unless it's your pulmonary hypertension is disproportionate to your lung disease. And so actually the people in the pulmonary hypertension centres to bend the rules a bit so they can treat people because they think it's helpful. But in terms of the evidence, then it's really not there at the moment.
Is it worth writing to the pulmonary hypertension people and just sort of checking that there isn't anything else that's coming along that they know about that isn't generally known about for patients with LAM? I don't know. Nick, whatever he's called, at Cambridge.
I find they go to Hampstead
think it's just so chaotic. I mean, they don't seem to know what they've done and what it means, and and in terms of addressing lifestyle, they're just useless. They don't. When I said, you know, because they said we have to be careful about exercise. Well, you know, how much? Oh, well, you should be able to talk when you're exercising. I'm thinking, no, I couldn't do anything and talk at the same time. It's a little more difficult, you know. Even walking, I have to stop. So I'm going to exercise. So you're saying I should do any? And I don't think
it might be just worth looking at, seeing if it could be taken on by the LAM Centre. I don't know.
You know, not the treatment, but then when I had this complication, they were totally baffled by it.
Yeah, I mean, it would be.
It's just not helping very much.
I don't know. I mean, it would be relatively few patients. It's not going to cost a lot of money if it's thought to be worthwhile. But it would be, even if you were doing it as a sort of research question, just to add in whatever it's called, bosantin, busantin. We'll talk about it.
No more questions? Oh. I actually need to go to the gym today. This is great.
Sorry, just a point from the last speaker, Neil Holden. He said about beta blockers affecting your breathing. So I'm just wondering what that's.
I don't think that's right in LAM, unless there's an asthmatic element. It's true for asthma. As he said, he's a psychiatrist, and I think it's perhaps sort of slightly muddling the two there. If you need a beta blocker, it's perfectly safe to try it and see, isn't it? There's no evidence. Some people find Ventolin helpful, and a beta blocker is doing the opposite. But there is what's called selectivity, so that you take the beta blocker as a tablet, so it goes throughout the body. You take the inhaler into the lungs, so you'll get more of the beta agonist, which is the opposite, in your lung, and more of the blocker elsewhere, which may be what's needed. But I can't see any reason not to try a beta blocker.
Anybody else while I'm up here? Okay.
Have you got any thoughts on what the optimal dose or blood level of rapamycin should be?
So the studies that were effective ran into between 5 and 10 nanograms per mil. So when we treat patients with rapamycin, then rather than an absolute dose, we try and get the blood level to the concentration in the blood between a certain level. And so we check this with blood tests. And Harry's asking what the best level is. So we know the level that worked in the study, and that's 5 to 10. But what we don't know, because rapamycin is a drug that stays around in the body for quite a while and binds irreversibly in the cell to its target. So it's probably there for a while. So we could perhaps give a smaller dose, or maybe a dose every other day, or I don't know. I mean, I tend, when I treat somebody with rapamycin, I sort of expect their lung function to stabilise rather than get a lot better. So once I've started treating somebody, if their lung function's stable, I don't mind if their rapamycin levels are 5 rather than 10. And actually I don't mind if they're 4 or sometimes even 3, providing everything's stable, because we don't know the lowest dose that's going to work. There's a guy in Japan, Kuniki Sayama, who has done a lot of work on LAM, who is starting to do an observational study of low-dose rapamycin to address this question. I think it's early days yet, but you sort of get the feeling that actually you can treat people with lower doses, and I do tend to run lower doses to try and reduce the side effects, because, you know, if you treat somebody with rapamycin when they're 30, you know, they might be on it for, you know, a very long time. And so minimising the side effects by keeping the dose as low as possible and providing the lung function stable, to my mind, is a sensible idea. So those studies will probably be done to find the optimal dose. I mean, maybe in the future it'll be rapamycin plus something else, maybe simvastatin, maybe one of these other new things. So a few new things on the horizon.
That's it. Okay. Thank you, Simon and Anne, so much.
Badges back so you can use them next year. I personally, I don't know if Kelly might do this, but I would really thank these young people that have given up their weekend to be with us because they're fantastic. There's still oxygen here if anybody needs to top up. I hope the Australian connection happened. Good. Okay, that's brilliant. And we appreciate your feedback, positive or negative, ideas for next year, what you'd like to see. Please email me. Thank you.
Yes, thanks everybody for coming. I think it's been a long day for all of us, but hopefully a really good one. I want to thank again all of those who presented. We got a lot out of the presentations. And I'd like to thank Jan. She pretty much single-handedly put this day together, so I think if we all give her a round. Yes, I was going to thank Team Mercer. Thank you very much. And thanks to John, Irene, and Julie Mullins for the raffle, running all of that for us. Thank you to Jane for digging up your garden. The plants are great. Everybody who made cakes and cupcakes. I know I'm leaving lots of people out, for which I apologize. There are nut cake and tea in the lobby. So please, if you can, stay around, and we hope to see you back next year. Thanks.